Okay, we are recording. So hopefully everybody can hear me okay after the technical issues I've had this morning, but I think we're there now. So a warm welcome to this training session for March 22, which is Understanding Limb Injuries and Limb Loss. And our guests are Jamie Gillespie, Nicole Bennett and Jason Robinson from Pace Rehabilitation, and we are delighted to have them. I just want to, for those of you that don't know, I'm Jill Fraser, the Clinical Director for Maia Rehab. And for those of you who aren't familiar, we provide these monthly training sessions primarily for our own rehab assistants to offer as many skills and insights as we can, and is over and above their mandatory training. This is at least monthly training we provide, but sometimes more frequently with relevant and interesting subjects, which any of us might use with our clients. Before I hand over to our speakers, I just want to highlight that our other sessions throughout the year usually take place on the first Monday of every month and cover various subjects, such as, I mean, it literally could be anything that's relevant, understanding depression and life change, living with pain, learning about the effects of brain injury, making sure your clients have their benefits, supporting clients to manage fatigue, manage anxiety, spinal injuries. We have speakers coming from rehab consultants. We have a session from a family of a client, and we have the perspective of the legal perspectives, which we had in January actually, but we will repeat that later in the year. All of it's helpful to the type of industry we work in. And we're all doing different roles, so it is useful to know. And in these sessions, we look at training which helps our rehab assistants to motivate the clients, and especially if they're not so easily engaged. Some of our clients, as you know, are very well engaged, and others are a little bit harder. But we help our rehab assistants to do things as basic as setting up their Google Calendar to aid their planning, but also so that the team, the clinical team that is involved, is able to share what is happening with the therapy and the rehab. And we help to teach things as, you know, as straightforward as practicing relaxation techniques, and suggestions on how to encourage, prompt and support rather than take over. So just before I hand over, I just wanted to stress that to our rehab assistants, some of who are here, but not all, they're always learning and identifying training needs. So this is going to be a very interesting one, as Kev said just now. Very relevant to some clients, less relevant to others, but still extremely interesting, I think. And it will bring attention to what else is out there for you as rehab assistants to work with. I mean, the clients you're with now, you're working very well, but it doesn't mean you're always going to be with that client. You might have other clients coming along and they might have these injuries that you might hear about today. So I think I'm going to introduce you now to this wonderful team from Pace who are going to take over. So we've got Jamie Gillespie. There we go. We've got Nicole Bennett and we've got Jason Robinson. So shall I hand over to you guys?
Thank you. Thank you.
Thank you.
Just share screen. Everyone see that? Yeah, so thank you for inviting us to speak with you guys today. So we were asked to give a little bit of an overview of dealing with patients with traumatic injuries, life-changing injuries, and how we help these patients from a prosthetic and orthotic point of view as part of their rehab, and how rehab assistants, how the local MDT can sort of play into this. So what we're going to cover today, just a brief introduction to who we are at PACE. We're then going to cover the patient journey. And when we look at the patient journey, we know at PACE we're part of that journey. We're not the whole journey, but just how patients sort of progress through their time with us and how the local MDT can support what we do. We're then going to look and talk individually a little bit about, from my point of view, it will be the therapy support. Nicole will then touch on to the orthotics and how these can play a big part in rehabilitation and how, again, how this can be supported when patients are back at home. And then Jamie will go on to talk a little bit about those patients who do suffer with an amputation, how prosthetic management can play into that. So PACE is a private rehabilitation company. We have a large multidisciplinary team and we work with patients following limb loss or serious limb injury. And the big aim of what we do is to help try and get these patients to reclaim their lives, get them back into the activities they would have done before. And that can be work, it can be hobbies, and it can just be as simple as that family life, you know, a parent playing with a child. And so, you know, that's what we tend to focus on, is really sort of making it patient focused. So what we're doing is supporting these patients to get back to who they want to be or who they were before. It's just going to be a short video now, just giving you a little bit of a heads up on what we like, our ethos.
This isn't an amputee. Just because they've got a prosthetic leg doesn't mean they're going to be the same as every other person.
When this happens to you, so you know, everything's over, it's finished.
This is a very unique place to work. It's a clinic and we have a service which we deliver, but we're absolutely working closely with people.
We are personally interested in what happens to our patients.
They've helped me in like so many different ways. They've offered me physio, aesthetics.
The emotional psychological background, I utilised what they had here. She was really good at working for quite a while. Well, we are an independent company. One of the best things about the job is that everybody's different.
It's all about enhancing independence for the individual in their environment, in their chosen activities.
Because they drive me on to be better. They know that I can be better.
They make you feel like you're incredibly important. And we met quite a few, you know, different people of all ages and all with very, very different challenges.
The best part of working at Vascular patients.
Thanks to Vinny, because like without these guys, I'd not be where I am today. They made me be able to just carry on being me.
So we'll start by talking a little bit about the journey a patient will experience when they come to PACE. So every patient who comes in starts with an Mdt assessment, and that'll be, depending on the referral, it'll be made up of 2 or 3 clinicians. And what we'll do is we'll spend an hour and a half to 2 hours with this patient, getting their history, seeing what their physical ability is like, and most of all, like sitting and find out what they want to do, where they want to go with their rehabilitation, what they feel that we can sort of bring to that plan as they're going through. So following that, we'll produce a report, and this will be sent back to the referrer. And in this, again, it will focus mainly on the clinicians who were present in that assessment, but during the assessment, we'll also complete a wellbeing questionnaire, which will be reviewed by a clinical psychologist. And again, it may have recommendations for assessments with the wider MDT that we have here at PACE. And again, that it can also have recommendations for assessments outside of PACE. So again, increasing the MDT that's supporting this patient locally. With our recommendations, we tend to look at a 6 to 12 month period, and we give recommendations for this period. We do this mainly to give that patient a bit of peace of mind that the rehab is going to be a smooth process, that it's not going to be a stop-start where we're having to get through a period of rehab, then go and ask for more money. And so we find this gives a bit more of a smoother transition to the patients. When it comes to the episode planning, again, something that we like to link in with the local MDT with here is that our clinical care coordinator will contact the patients, will contact the referrers, the case managers, and make a plan alongside our sort of clinical diaries. So we will give patients, 4, 6, 8 weeks worth of appointments up front, so that if they are coming to work with us and they're not local, which a lot of our patients are not, hotels can be booked, accommodation can be booked, and it takes the stress off of the patients coming to see us. When we're going through treatment, again, we like to keep the MDT, the wider MDT, not just our clinical MDT here, up to date with everything. So we will have regular meetings where this can be done over Teams or Zoom, or there'll be regular update reports. Again, we find this just helps with the patient getting a consistent message from the whole MDT. So they're not seeing one clinician who's saying one thing, someone else who's not had any input or conversations with us as treating team, then giving different advice. And then as we're approaching the end of our treatment, we will often provide further updates and recommendations going forward. And so again, sometimes these recommendations are for further intervention or further work at pace, or it might be for ongoing work with, from a physio point of view, I'll often recommend that there's a local rehab provider found, or a personal trainer, someone to continue the work that they've started here when they may not need the sort of specialist input as frequently. And then from that point of view, as a physio, I might look at seeing a patient on a bit more of a review basis, but being able to then link up with that local MDT to provide ongoing recommendations.
So I'm going to talk a little bit about early intervention and why it matters. I think all of us who work clinically can all appreciate that the earlier you can start intervention, the better. And there's a lot of evidence out there that very much supports that. So I just want to home in on the evidence base that supports early intervention. So very conveniently in January, the NICE guidelines were published. I think most of us have had the opportunity now to sit with a cup of tea and read them. But one of the key things that kind of was drawn out from that was the importance of early rehabilitation, and ideally starting as soon after surgery as possible. As soon as that patient can engage, the therapy team should be getting involved with that individual, and that momentum that's built while they're an inpatient in an NHS hospital should continue as they're discharged home. Starting exercise early, pain management, splinting, swelling management, all of these things should be looked at early doors. Now, one important study I just want to draw everyone's attention to, anyone who works in lower limb trauma injuries, the largest study that's ever been conducted is the Lower Extremity Assessment Project, which was a US study. And it's a really important one if you haven't seen it to try and get hold of it. So that's a study that looked at 569 patients who had sustained a lower limb injury following trauma. And they followed these patients over a 7-year period to gather outcomes. So they did a kind of consensus at 2 years and at 7 years. It's a really interesting study, and it talks about amputation versus limb salvage and the outcomes in that. So if you get a moment, try and get hold of it. But I just want to focus on the things that were pulled out with regards to early rehabilitation. And this study said that major improvements in functional outcome require interventions in the early post-acute phase of rehab, and engagement in quick physical and psychological intervention improves secondary problems. Now, the other kind of evidence base that very much supports early intervention is the military side of things. So military rehab is set up to provide that intensive early rehab because that's the model of care that the military provides. And certainly myself and other colleagues here at PACE had the opportunity to work in that kind of environment. So we all very much appreciate the importance of that early rehabilitation model. But it comes as no surprise that there's a multitude of different papers from the military that support early rehab. So as I said, we're all in agreement, I think clinically, those of us on the ground working with patients, that early rehab matters, and certainly the evidence base supports that too.
So as Nicole's just touched on there, and as Jill was touching on in her introduction, you know, it is all about the team. It's about having the right team in place to help these patients. And at PACE, we're very lucky, especially clinically, to have a large MDT more than often on site where we can pull each other into sessions. You know, it's not uncommon that I'll be in a session and I might notice something, pull Nicole in or pull Jamie in, and it gives the patient that sort of reassurance that they're getting seen from head to toe, because it's that, you know, rarely does a trauma patient turn up and they have just one injury. You know, it might be that we see someone who's been referred because they've become an amputee, but then on the contralateral limb, they've got a nerve palsy, which is causing a foot drop, which is where orthotics then come in. And so from a therapy point of view, actually looking at the patients holistically, make sure that we can then best manage their needs. And then that's when it then comes into making sure that the local MDT can then support that gap. So like we said, not many of our patients are local. So we may see a patient for 2 days of quite intensive treatment, but then we don't see them for 2 weeks. And if there's no input within that 2 weeks, then you don't sort of get the progress session on session. For some patients, you're going to give them their exercises or give them some advice and they'll follow it to the letter. Some other patients, they need that little bit of support, that little bit of oversight, just to continue that progress between sessions. So when we're working with patients, it's all about considering the individual, and this is done on a session by session basis. So we'll have an overview of what we're treating and why we're doing it. But as a therapist, when I see a patient, it's, right, what are the injuries? What are the issues today? So it's always starting with a good 10, 15-minute chat about how they're getting on, what they've been doing, what's changed. And then it's factoring in, is this due to the reason they're here, the referral, so the amputation or a complex fracture that they're getting over? Do we need to take that into account? Again, we have patients who turn up who, especially in the early stages, may have restriction on what they can do from the doctors or the consultants in terms of non-weight bearing. And so then it's looking at the input required in that session. So from a point of view, most sessions here, patients will receive physiotherapy or occupational therapy, and then it's the input from the orthotist and prosthetist around that to support that. And again, they will be able to drop in and out of those sessions. And again, it's not, like I said, it's not uncommon that we will see patients with 2 or 3 clinicians popping in and out during a session. How can this be helped at home? A big thing that we like to do is joint sessions. So working with the local MDT, working with family, because again, these patients, especially when they're new into this, there's a lot going on. They're being given a lot of information, and especially if they're being given an orthoses or a prosthesis that they may have never seen before, never used before. Knowing how to put that on and off, knowing how to maintain, that's really important. So having people turn up at the sessions who can accompany them, especially in the early stages, you can just give that little bit of advice to help them, nudge them to make sure that they're learning good habits early on is really important. Another thing we do a lot of work on is finding out what motivates our patients. So when we're working with them, it's what are their goals? What are they aiming to get back to? And like I said at the beginning, it could be as simple as being able to interact with their children. There could be specific hobbies, it's getting back on a motorbike. In this chap's case, it was getting back playing football with his friends. And so that really helps us because it helps with prescription in terms of the orthoses and the prosthesis, but it also helps from a therapy point of view to make that relevant. And then being able to share this information with the wider MDT, someone like this chap here, where football was a big thing, it's bringing little bits of rehab in that make it relevant to him so that he wants to engage in the exercise. A lot of patients, if you give them 5 exercises to go home and work on, can have that early sort of impetus to do it, but that can become quite mundane quite quickly. So then being able to vary it with little bits. So for this chap, we'd be in a session, he'd be doing balance work whilst heading a football back to me. Again, it's that sort of thing of just making it relevant to that patient so they can see why they're doing this rehab. So rehab, it's a difficult process, and again, there's a team effort to it. But the big thing that we've got to do here, when you're learning to use a prosthesis or an orthoses, is it's promoting that independence and that confidence to use them, and that comes through repetition. Again, these are new bits of kit, and as I said, but after a few weeks, people will know how to put their prosthesis on, will know how to put their orthoses on. But what can happen is that people then start to sort of get up and run before they can walk, and that's where we then start to get secondary complications in that can arise, and that can be the common ones that we'll see in physio is a prosthetic user gets their leg, can get up and walk, which is great, and it's something they've been aiming for probably for a fair few months, but then they start to push themselves before they're ready in terms of their balance, their strength, their movement control, and then they are walking with some gait abnormalities, which could be an increased postural sway, which in the short term may not cause much of an issue, but then over time this turns into a lower backache at the end of the day. Over time this becomes more and more chronic if it's not addressed, and so it's about making sure that we're progressing these patients, but when we're giving them the advice of gradually build up your tolerance of wearing your prosthesis, it's not all about skin tolerance and making sure there's no breakdown of the skin when you're wearing a prosthesis or an orthosis. It's also allowing your body the time to build up that ability to be able to manage walking on these devices, which do alter gait. They help you get up and walk, but they don't allow you to walk always exactly how you would have done prior to your injury. So I've listed a few of the modalities that I'd regularly use, and again, physio, there is a lot more that gets brought in, but these are some of the tasks I will regularly do with a prosthetic or an orthotic user. You know, strength and conditioning plays a large part of what we do, and again, that's that whole thing of having exercise done here with us. Doing a couple of sessions over 2 days is great, but then if they're not doing anything for the next week or 2 weeks at home, that becomes really hard for there to be any carryover. So that's when they're sent home with strength and conditioning sessions or home exercise programs. It's about, you know, the local team knowing that they've got those programs there, being able to nudge them to say, you know, have you done your exercises recently? Have you, and again, it doesn't have to be going through the whole program. I'll regularly say to patients, you know, fit in 1 or 2 exercises a day just around what you're doing. But I said, if you're doing that every day, you get those little gains that are moving forward. Lots of what we do is, like I was just touching on, is the early gait re-education, the functional task and training. A lot of that starts within the clinic, but as you'll see with the picture on the right, you know, it's about getting people back out into the community, out into the environment, because learning to walk in a prosthesis within a controlled environment where it's flat, there's no distractions, that can get quite easy, but that can give false sense of confidence when you then get somebody out into the real world where there's traffic, there's people walking the dogs, there's children running about, there's uneven surfaces, there's different wind, you know, elemental conditions in terms of wind, rain. It's being able to adapt all of that. So a lot of our work is done outdoors, and again, a lot of our instructions to the patient will be around, okay, right, you're doing this well, you now got that confidence, go for a walk in your local park, you know, go with a friend, go with family, go with a rehab assistant, someone who can be there to give you that little bit of confidence, but just to help you going forward. And then, like I said, it all ties in at the end to that goal-specific training, working patients back to where they want to be. And as we go through this, you know, a big part of what we try and push here is the psychological support when it's needed, because again, if patients are not, if you like, not built up that resilience, so they might be that they're coping in a fairly controlled environment, but as in all rehab programs or in daily life, you know, we have those little bumps that we hit. It's having the resilience and the management strategies to get through that allows the physical rehab to keep going. And then that sort of plays into the occupational therapy then input, which again, we provide here for some patients, or is done from external sources in others, but getting patients back into work, into school and its children. And so it is about looking at that larger MDT, both within PACE and with outside. So I think my big thing to anybody working with these patients locally is don't let things go to waste. As Nicole was touching on, it's never too early to start. You know, you might be limited and restricted in what you can do to start, but, you know, getting patients to, you know, to walk with their mobility aids, if they're non-weight bearing, it's making sure they transfer sitting out, that they're not spending long periods in bed or, you know, not moving about. Wheelchair use can be a really good one for traumatic patient trauma injuries at the beginning, because again, it gives you some sort of independence and mobility, but it also gives that cardiovascular fitness if you're going outside. So again, it's assisting where needed, but also encouraging the patients to do that a little bit more. I'd also say, when you first meet a patient, you know, ask them if they've got any home exercise programs or stretching programs. Most patients will leave hospital, should have done some work with a physio. It doesn't always happen, but if they have, it may be a good chance that they've been given an exercise sheet or something to follow. And so sort of encouraging this, and then, you know, hopefully progressing that as they start to work with us here and we're giving them more to work on, that can then play into building up that strength and ability to be able to use the devices that are then getting prescribed. I suppose in this one, anyone who's worked with patients who've gone through this, they know rehab's not a smooth process. You know, there are ups and downs. Patients are going to have good periods and bad periods, and I always find it's sort of trying to help these patients tie into where they've come from. So, you know, when they're in a bad period, or they're in a low period where potentially their leg's swollen, they can't get their orthoses on, or they've got some skin breakdown and they can't wear their prosthesis. It's then going, okay, right, this is hopefully a small blip. We let this settle, but, you know, there is work that can be done around this. There is exercise you can still be getting on with that's going to benefit you when you get these devices back on. A big one we have is the sort of boom and bust. And again, this can be really helped by people who are working locally when we're not seeing the patients, is that they've spent a long time unable to get up and walk or unable to do the activities they want to do, we then provide them with a device that allows them to start doing this. And it's that thing, as I was mentioning earlier, it's that condition, it's wanting to run before you can walk. And it's making sure that we are not getting into that cycle of they do too much because they've had a good session at pace, and then they have a good day because they've done that, and then the next 2 weeks they're waiting for their leg to heal up to get on with their rehab again, because that just then slows the process down. So again, having that sort of MDT work where we're communicating and saying, you know, make sure we're prompting patients not to push themselves. And again, it's, you know, it's done with a loose leash, if you like. We want patients to be pushing themselves, but not to the point where they're then hindering their rehab. And from personal experience, I'd say most patients at least go through the boom and bust cycle once, because they, you know, it's that thing when you've been desperate to get doing something, you suddenly can, you push yourself, and it's hoping that they learn from that. Because the other thing that we, you know, sort of plays into that is when we get the unexpected delays, so like infection, or I've had patients recently who have had falls when not wearing a prosthesis and then got big bruises on their residual limbs, so they can't put the legs on. Again, patients who have got other illnesses, other conditions that may cause volume changes, these can all cause delays to the rehab. And what we want to do is make sure with the, you know, those top 2 points, the ups and downs and the booms and busts, we're not then further delaying it because we're not progressing them in the manner that we should be. Moving forward, I said, you know, like I said earlier, you know, we're only part of the journey here, but what we find works really well for patients is setting goals. So, you know, in that first assessment, our patients telling us these big goals they want to get back to. And for us, that's great. That gives us our target, but it's also then making sure that we're keeping that realistic with the patients. Because if patients are so focused on the big goal, they start to lose sight of the progression they are making because they're not achieving that. And so it's breaking those big goals down, again, giving it relevance to them, but making sure they're moving forward and they get small frequent wins. You know, having that achievement once a week or once every couple of weeks, it buys in motivation, it gets engagement from patients, which is really important for them to have a successful rehab program. Again, we can help and the local MT can help, but we need to have that buy-in from the patients if they're going to have that movement forward. And again, looking at those goals around the home, that can be facilitating ADL. So, you know, as Jill was mentioning, it is enabling these patients, helping where they need it. And again, helping to don a prosthesis or an orthosis in the early stages, but as soon as we can, getting them to the point where they can do this themselves, looking at the things they want to do around the house. You know, an orthosis and prosthesis can help with this. But if you're working with these patients regularly, looking at what else may be worthwhile in the house, you know, that's where the occupational therapists come in. So mobility aids or aids for ADLs, are really important, so that we are enabling these patients and we're empowering them to be in control of their rehab instead of a sort of participant and just a sort of passenger that's being instructed constantly.
Jason, can I ask a question?
Yeah, go for it.
Would you support the rehab assistants who work with your clients coming to your sessions so that they can learn as much from you as possible, and maybe you could provide them with those exercise programs in between your visits, etc.? Would you encourage that for
no, we often have people in the building. And we find that really, like I said, especially in the early stages, that can be really helpful, because I said if we're giving a patient a lot of information, trying to retain all of that when they're also going through the rehab can be quite difficult. It's quite tiring. So we're more than happy to have people in the building to join sessions. Again, that can be family members or it can be rehab assistants, as I said, however the patient wants to sort of go forward.
It's not uncommon for Jason also to go out and do local visits to work with local teams. And so that the therapists here are not just working in the building, that they are going outside. And I think that's really useful.
That's really helpful. Would you also be available for I think I know the answer to this, but just either the rehab assistant or any of the team calling you with any concerns and things that they're not sure about? You know, something might be, you know, the frame might be a little bit tight, or, you know, something like that. Would that be something that we could tap into for you?
And that's where we like to use those sort of MDT meetings, like for updates, because I said it gives us a chance to get to know people and hopefully break down some of those barriers to being able to pick up the phone when you've got that face to sort of put a name to. It makes it easier to pick up the phone. But yeah, I'm regularly on the phone chatting to people, and so the guys here are talking about management if there's issues when patients are away.
Lovely, thank you.
So what I'm going to focus on now is just a little bit on orthotics, just a little bit more. So an orthosis is a device which is applied externally to the body, which is trying to achieve the following goals on the right hand side of this slide. So it's trying to control biomechanical alignment, correct or accommodate for a deformity that's present, try to support or prevent injury. Obviously, all of these devices are trying to assist rehab. Some are purely cosmetic. That's not so much anything that we on this call would be focusing on so much. And everything we're trying to do generally is trying to reduce pain and increase mobility. And the different pictures here just give you an idea of all the different devices that could be applied, anything from head down to toe. So I've focused my next two slides on the needs of the early patient and more the established patient. So if we focus first on the early patient. So as Jason has said, a lot of this is around trying to get in early to try and prevent those secondary complications that come down the line if left untreated. And these are the kind of things that I would be looking at as an orthotist in the early days. And the goal being that I'm going to spend as little time with the patient as possible, because every moment that the patient is with me, they're not with Jason. And in this early stage, we want hands-on rehab. We want getting the patient up and about and moving as much as they are able to, and engaging in everyday life. So myself, and I think Jamie would agree with this, we're very much the support staff in this phase, just trying to help that individual to spend as much time with a core therapy team as possible. So things that I'm trying to get involved in. So one thing is joint contracture. So if somebody has been non-weight bearing for a long period of time, is in a wheelchair, has maybe not had a lot of intervention through their NHS phase of their management, quite often individuals come with joint contractures. Sometimes the limb is very swollen. That also kind of plays into the contracture. So what we're trying to do is trying to limit that. So that may be applying a splint directly onto a leg. That might be a static splint, a dynamic splint. It might have a contracture hinge. So there are some hinges available that apply a pressure to the limb. Or it might be rigging up something like the picture on the right hand side attached to the frame. So there's various different things that either you can custom make onto frames or you can buy in and attach onto frames to try and keep that ankle at 90 degrees. And it's really, really important because there's nothing worse than somebody having gone through all that limb reconstruction surgery, have spent months in one of these frames, and then they finally get it off, they get to go, and their foot's stuck in a plantar flexion contracture. So it's a really simple thing that we need to get top of early, because it can cause so many headaches and problems down the line once that frame comes off. Scar management. The earlier we can get working on scars, the more chance we have of increasing the flexibility of that scar and trying to flatten and smooth out that scar. So anything that we can do from a scar management point of view as early as possible, we'll try our best to. Compression, managing swelling. If obviously someone's got a frame on, there's limitations to what you can do, but as soon as frames come off and as soon as possible, we should be trying to apply compression where we can to try and get swelling down on that limb. Hopefully, with engagement with the physios and whatnot, that actual natural pump will engage when they start doing weight bearing exercises and start getting back to everyday life. But certainly compression garments can help with that. Early access to a rehab consultant and psychological support is important. A rehab consultant in particular is important because quite often these individuals, they have infection in the early days, revision surgeries are not uncommon, and a rehab consultant can very much inform the whole team, including the surgeons, what the least impact could be on rehabilitation. So they're best placed to help map out those surgical procedures and to tie everything together to keep the rehab process as smooth as possible. And as Jason's alluded to, in this phase, there's so many appointments, it's information overload. So us all working together and communicating as one to ensure that the key messages to the patient are getting through is really important. So when somebody then moves on from rehab, so we're kind of past those early days and we move more into what we would kind of class more as an established patient. Some individuals need orthoses forevermore. Some people only need them for a short period of time. It depends on the injuries the patient's had. And very much orthoses in this phase are geared towards improving function and reducing pain. Typically, most things that we see here at PACE are custom made. And to customise these devices, we either take a cast of a patient's leg or we take a 3D scan of a patient's leg, for example. And most customised designs, they have a check fit phase. So you would have an intermediate diagnostic where you just check volume and you check the general fit. So the whole process from start to finish, so from when you cast an individual to when you fit something, for what I do is roughly about 6 weeks for that process. The individual needs an orthosis that they can trust, and most people would have a spare in case of any breakages that were to occur. It's not uncommon for individuals to have multiple different orthoses. If you are tackling, for example, pain, you're less likely to have multiple orthoses. If somebody has a nerve injury, they're much more likely to have multiple different devices because not one device ticks all boxes. So sometimes we have individuals who would have devices for specific sport. They would have an everyday device. They might have something that they can take into water and kind of beach type activity. So something maybe in silicone, for example. With dress shoes, sometimes individuals have to go to a wedding and their everyday orthosis, which is absolutely fit for purpose for their everyday needs, doesn't fit into their stylish shoes that they're going to wear with their suit to a wedding. So sometimes we have to design things for different purposes. The biggest frustration, without doubt, for orthotic users is footwear. So this is where certainly therapy assistants could be really helpful to us. So we provide an individual with an orthosis. Most patients are unilateral, so it's just one side. So it's very common for somebody to have to go up at least 1 or 2 shoe sizes. And quite often I have multiple conversations with patients where they send pictures of shoes back and forward. Is this appropriate? Is this not appropriate? What would be really useful would be that could be something that a therapy assistant could go shopping with the patient and could go and try and find a suitable footwear to fit that orthosis. And that's probably something we should take up separately around kind of providing some guidance for therapy assistants to go shoe shopping for patients. That would be really, really helpful because it's a huge frustration for patients and causes a lot of issues. Once we get a shoe that fits the orthosis, everything's great, but it can be very tricky for patients sometimes to find appropriate shoes. And managing change. So individuals, as I said, have revision surgery. Sometimes they may down the line end up, for example, going for further foot surgery. It changes the structure of the foot. And we need to manage that change along the way. So sometimes we have to re-specify orthoses, we have to recast orthoses, managing all the things like chafing and sweat and so forth. And how you as a team could support us, so feeding back things like any pressure issues that we're not aware of. We're obviously paying attention while patients are here, and we always invite patients to get in touch with us straight away if there's any concerns. But some individuals are a little bit slower to respond than others. So certainly if you notice any skin changes, anything on the orthosis that doesn't look quite right, so if you were to spot, for example, a crack or a strap that looks like it's frayed, any information at all that you guys can provide us with also is useful when patients aren't here on site with us. And that's how I think we can all work together.
It's my turn now. So I'm Jamie. I'm one of the prosthetists here at PACE. I'm one of 7 or 8 prosthetists working for PACE, and obviously we're quite busy working with patients who have undergone amputation and working with the amputation stumps. Our colleagues on the NHS will typically be working with patients who have undergone amputation as a result of vascular complications, diabetes, vascular disease. At PACE, our cohort of patients is slightly different in that the majority of the people that we work with have either undergone a traumatic injury where amputation has followed quite soon afterwards, or a traumatic injury where there's been an extensive period of limb salvage and perhaps orthotic use, which has resulted in the person then electing to have an amputation later down the line. But typically trauma is the cause of the original injury. So on the screen here, I have a picture of 3 different types of amputation stump, and the point here is that every single amputation stump that we work with is different. There is no 2 that are the same. The picture on your left is a chap I was working with in clinic yesterday, who was a traumatic amputee. his amputation stump is a majority of the skin is skin grafted tissue, so extremely delicate, fragile tissue that's prone to breakdown in response to shear pressures or peak pressures within the prosthetic sockets, and it needs careful management. The chap in the middle features quite a lot during this presentation, a double through the knee amputee as a result of trauma. Amputation was carried out pretty much at the scene in a traffic accident, and the challenge there, of course, is that he's a double amputee, and we're working with two amputation stumps and all the complications that go with that. The picture on the right looks much more straightforward. It's a trans tibial below the knee amputation. This is a chap who was an ex-fireman who retired from the fire service, had a motorcycle accident, and on the surface there, it looks like a nice, well-formed, matured amputation stump. But what we were dealing with in this case is underlying neuropathic pain. So he had pain associated with nerves that are outside of our control as physios, prosthetists and orthotists. And it needs some careful pain management and coping strategies to deal with the pain. So what can be simple to the eye is actually, it can be quite difficult to deal with. A huge variation in presentations is what keeps us busy. We also need to manage expectations. You can't switch the TV on these days without seeing an amputee on one channel or another. You know, we've got amputees on Strictly and Dancing with Ice and Celebrity Hunted. You open a magazine and there's amputees being featured in advertising features. The diversity is fantastic out there. But we also need to understand that the patients will be looking at this, and this is where they're setting their bar. They see very young, active people wearing prosthesis and think that's the norm, and actually it's not. You know, majority of these people are athletes, professional athletes, and spend their time taking great care of themselves and being in the best physical shape and condition they can be. And it's not representative of the normal amputee population. So as well as managing the amputation stump, we also need to manage the expectations. And we do hope that people will exceed our expectations and will achieve and do well on their prosthesis, but not everybody will. And for some, just getting back to independent walking will be the goal. So this is the process that I would typically work through. We can work with an amputation stump as early as 3 to 4 weeks following amputation surgery, which sounds quite soon, but there are certain procedures that we can do to get somebody up and using a prosthesis, even if it's an interim prosthesis within a therapy session only. After amputation surgery, there's a great deal of swelling usually from the amputation stump, and that swelling is going to take some time to go down, and it can be a year to a year and a half before it starts to settle to an established shape and size. So it's a moving target for us for the first year or so. What we hope to achieve, even before the prosthesis is introduced, is that we try and reduce the swelling as much as we possibly can, so that when we're in a prosthesis, we don't have to keep changing the prosthesis every couple of weeks. We know that we are going to be changing prosthetic sockets in response to volume and shape changes, but we want to keep somebody in therapy, as Nicole mentioned, for as long as we possibly can before we step in and cause an interruption. So the normal process is that we apply a silicone or a gel interface over the top of the amputation stump. So pictures here showing measurements. We carefully select the size and the type of the interface, of which there is a wide range. And that then is used over the top of the skin. And the idea is to some of the loose fleshy tissue is contained, so it's a little bit more stable within the prosthetic socket. There's also a layer of silicone or gel material between the skin and the prosthetic socket to offer some protection, so that any rubs and pressures will hopefully be absorbed by this material rather than being transmitted through to the skin, leading to breakdown. Over the top of the amputation stump and the interface, we take a plaster cast. More often than not, there's several ways to capture this information. Plaster cast is more traditional, but it's something that most private companies in the UK are still working with extensively. Some NHS contracts have electronic ways to do this, but I'm yet to meet a patient who tells me their most comfortable socket they've ever had is being done by any other method than a plaster cast. So we are getting plaster under our fingernails regularly. We take casts. that plaster shell is then filled with liquid plaster of Paris. There's a series of measurements and skeletal references that are transferred onto the cast. We then strip off the outer shell so that we're left with a positive model of an amputation stump. This is where we put some music on, we make a cup of tea, we head to the plaster room, and we spend the next hour or two thrashing away at a lump of plaster that is somebody's amputation stump. And we're going to change the shape of that according to anatomy and knowing where we can take pressures and where we can't take pressures. And we're going to change the shape so that we can then use this as the mold over which the prosthetic socket is produced. Now, working with plaster it seems quite old-fashioned in this day and age when we have a whole lot of electronic means available to us. But it is the preferred way to do this across the world in our profession at the moment. That may change in the future, but here and now, this is how we're doing it. And typically somebody needs a good deal of experience over time. You know, within your first year or two after graduation as a prosthetist, you're not going to be a master of your trade. It's going to take some time. So typically people who are working in private practice within the UK have a good many years under their belt. We don't typically recruit graduates. They will often go and learn their trade in the NHS, and then the good ones will find their way outside of the NHS over time. It's a very difficult job, and the volume of work that the NHS colleagues are doing can mean that the experience is gained quite quickly. Over the top of the plaster model, we then produce a prosthetic socket. And now this is slightly a different way of working to our NHS colleagues. We typically go to a temporary stage. So we make a prosthetic socket out of plastic. The plastic allows us then to look through and see how well or how not is fitting to the patient. We have a series of these up our sleeve, which we're going to be making over the next months once we start working with a patient. We use a type of plastic here at Pace, which can be used safely outside of clinic. So we reinforce the plastic socket once it's connected to a prosthesis. We then send that away to be used outside of clinic and used with therapists, either therapists within our building or local therapists or local supports. And we want to understand what's happening to the amputation stump when this is being used in the real world. Walking up and down within a set of parallel bars inside of clinic, we know that's not the real world. Once people hit cambers and slopes, upstairs, downstairs ramps, they're going to find out where the socket can be improved. So this stage is very important to us. A new amputee coming to us is typically going to stay on a temporary prosthetic socket for about 5 months following amputation. We're in no rush to convert that to a finished socket, because once we finish the socket, the options for adjustment that we have are quite limited, and we're also very aware of the cost involved. So it's much more cost effective for us to factor in a series of temporary sockets for a new amputee that may be up to 6, which we would work with over a period of 5 to 6 months before we have a much more established and settled limb, and then we can produce the more definitive and finished looking socket. The NHS, as I mentioned, don't have this luxury. They may produce a socket which they can evaluate very quickly in clinic only, but they don't go outside of clinic. And so they move quite quickly to a finished prosthetic socket. And a few weeks later, it's not uncommon for issues to come to the surface, which then need fixing, and the whole process starts again. Once the temporary prosthetic socket has shown to be good, and we know that the amputation stump is settled, we'll then convert that into something that's a little bit more permanent, a little bit more finished. Apologies for the resolution of these pictures. This was a lady I worked with many years ago, a lovely Mexican lady. We were able to travel in a past job. I was able to travel around the world quite a bit with her. It was absolutely a pleasure. But what I did notice when I was traveling with Anna is that very small differences to altitude, very small differences to climate would have an effect on the quality of her fit of her prosthetic socket. If we were somewhere, for example, in Mexico City at altitude, that would have an effect on her amputation stump. If we were down at sea level, amputation stump would be slightly different, and the fit would vary. If we were in a hot country, she would typically get a little bit more puffy, and if we were in a cold country, then the volume would come down a bit. What I'm producing is more often than not a fixed container, And if we've got a moving target of the amputation stump, then it just needs careful management. Often the patients will be very good at learning this, but it does come over time, and they do understand all the tricks and tips which they can assist with their own comfort, with the use of some socks, for example, or managing some creams, or just an understanding that they might need to spend a few more minutes in the morning just moving into their prosthetic sockets. So the picture on the left here is a more finished version. It's a basic type of prosthetic knee and foot connected to a socket. And in this case, it then was covered with cosmetic foam and a bespoke silicone cosmetic cover, which looks very good. The reality is that this makes the leg a little bit more heavy. If we have silicone that comes over the top of the knee joint, it does restrict the function of the knee joint. So most amputees will take a very fancy cosmetic cover to the knee only and not take it above the knee. A big part of what we do here is to select the most appropriate hardware, the most appropriate prosthetic components that go underneath the prosthetic socket. We are aware that in the background, more often than not, for those people who have been injured, there is a legal process, and during that legal process, costs need to be considered for long-term prosthetic use. To allow the experts to come to a conclusion regarding costs, we have to carry out a series of trials and understand what is the most appropriate prescription. So during our process, once somebody is a little bit more established, it's common for us to then investigate different designs, whether that be prosthetic knees or prosthetic feet or both, to understand which is the best combination for that user. The pictures that I've put on the screen here are some high-end equipment. The costs are eye-watering. You know, we can have prosthetic knees which are 50, 60, 70,000 pounds. We can have prosthetic feet of the same cost. It's not uncommon for an above-the-knee prosthesis to be up close to 80,000 pounds. So extremely expensive equipment, and it needs very careful consideration. So our trial procedure is quite extensive. It involves the whole team, and we are looking to see what works best for each individual. As Nicole mentioned earlier, there is no one orthosis that does every job we want it to, and it's the same in the prosthetic world. It may well be that an amputee has 2 or 3 different designs of prostheses, allowing for use day-to-day, use in water, and also use with sports. And then we can choose how they look, the appearance of those. Most people these days tend to have no cosmetic finish on their prosthesis. They're quite happy to walk down the street with some of the hardware exposed, and we're happy with that. People will have colourful designs of sockets, and there may be some 3D printed or plastic injection molded covers that go over the top to add a little bit of bling and shape and colour to the designs. That's probably more popular these days than a silicone cover for us. So that was fine, but the reality is, day to day in clinic, I'm kept busy managing skin issues that do occur as a result of prosthetic use. And these can be wide-ranging. They can be pressure from the prosthetic socket because the socket is not fitting as well as it could be and needs adjustment. They could be ingrowing hair follicles. I have a couple of chaps at the moment who suffer from ingrowing hair follicles, and it's causing them some headaches. We can have issues at the end of the amputation stump because of delicate scar tissue, or vacuum pressure causing us some issues. In the summer, everybody gets hot and sweaty within the silicone or gel liners. It's a known problem. It does get easier over time. There is no magic solution to take it away if a prosthetic socket is being used. And it's not uncommon for us to see fungal infections occurring of the amputation stump. And again, this is where a rehab consultant is key. They can provide support advice and even prescribe some creams that can help manage this, or antibiotics if need be. But for most amputees, there is going to be careful prosthetic management needed, and there will be issues over time. It's very uncommon for us to work with somebody who has such a smooth journey over the long term of their early rehab where they have no issues at all. So it's my job to try and minimize these issues as best as possible and keep them with Jason and our therapists in clinic. But the reality of the situation is progress will be made. We will find an issue, or an issue will come to the surface. It needs to be carefully managed and then back into rehab as soon as possible. it may mean that we have to change the socket design or the materials that are used within inside the socket. Again, everyone's different, and I have to consider the whole range available to me.
And on that point, there is therapy input can also cause some of these issues. So like we were saying, it is about making sure that if you're working with these patients, you're regularly checking their legs with them, especially in those early phases, because too much on a socket too early can cause some of these issues, which then causes issues for the prosthetist trying to sort of resolve them.
Yeah. So here's the chap that's been featured throughout the presentation. He came to see us in September several years ago in a wheelchair as a very recent amputee, and his ambition and aim was to walk down the aisle. 8 to 10 months later, we were able to help with that. But the point here is that the work in between the picture on the left and the picture on the right should not be underestimated. Even for a single leg below the knee amputee, it's a considerable investment in terms of time and effort and hard work to get somebody up on their prosthesis. And the higher the level of the amputation, that becomes harder. And then once multiple amputations are factored in, it becomes even harder still. It's a very, very difficult journey for these people. And we're here to try and make that as smooth as we possibly can. But we shouldn't forget the amount of effort that is required. Very, very difficult. And it needs all of us to play our small role to get these people back to normal life as best as we can.
So just a little bit about our lower limb trauma clinic. So we have a lower limb trauma clinic here in our clinic in Amersham and also up in Bredbury in Cheshire. And that's a service that focuses on early rehab for serious injuries, including lower limb loss. It's a consultant-led Mdt assessment with a team of experts who are all senior professionals who have worked with injured military personnel or have worked in London trauma centres. And we form a comprehensive rehabilitation strategy that's fully costed and gives you confidence for your patients. Rehabilitation is always delivered flexibly to best meet the patient's needs, and we deliver rehab in a variety of different settings. In the early days, that's more focused around the patient's home and the clinical setting. For what Jason alluded to earlier, individuals need to have access to the full MDT throughout that early phase of rehab. So being able to nip in and out is really important. But as that patient progresses, we often deliver rehab in the community, coordinated appointments, whether it be in clinic or somewhere like the gym, intensive bursts of rehab. And that's something that the NICE guidelines touched on, was the importance of those intensive bursts of rehab. And they come at different stages in someone's journey that are appropriate to use. In particular, when we're talking about things like returning to work and so forth. So as I said earlier, this is where our clinics are located, so you can see on the map. And we also have a satellite clinic up in Glasgow. The lower limb trauma service is only available in Bredbury and Amersham, and the satellite clinic in Glasgow is very much a prosthetic rehabilitation service. Any new inquiries, you can refer to us via our website. Scott Richardson is our first port of call, so his details are on the slide here. And it gives you a general idea of the documentation required that Scott will be asking for when you get in touch with them with regards to new referrals. If
you're not sure what's needed, then my recommendation would be just pick up the phone to Scott and just have a chat. We've been doing this for such a long time, and we're able to suggest different options, and that may well be that somebody pops by for a cup of tea before any formal activity begins. So yeah, any questions whatsoever, just pick the phone up and have a conversation. And thanks very much for your time, everybody. If anyone's not already registered, we're holding a conference in London on the 22nd of March. All of the team will be there. It'd be a great opportunity to finally get to meet people face to face. So hopefully you can join us. Thank you.
Thank you all so much. That was fascinating. That was so good. I mean, I recognised certain people there, which is great. It's great to see and remind myself of the journey that particular client had, and now we've got another one very similar, haven't we? Which is great. So it's been great working with you in the past as well. One of the things I'd like to ask, and I'm sure other people have got some questions as well, is you pointed out some things that maybe some of us wouldn't be aware of, looking at the skin integrity, watching out for certain potential issues. And when the rehab assistants and all of us actually, when we're working with our clients and they're not in clinic with you, we're trying to obviously monitor them, observe them, record how they're doing and the progress they're making and the issues. Now we focus a lot on simple issues like, how is their mobility, how their transfers and that sort of thing. But we can also, the records that our rehab assistants complete are electronic. They all have their own tablet, and we put together their recording sheet as according to their goals. So if you were to say that that one of the goals of our joint client is managing their skin integrity, etc., or something like that, we can add that to our daily recording sheets. But we need to know what to look for. So that's been really interesting for us, and we can add that to the records, which you can then look at whenever you want with our clients. You can then say, how is that skin looking this week, or how did you manage that transfer, or how did you manage that exercise? So I just wanted to put that out there that we can do that. I can't see anybody's faces here.
Yeah, we're more than happy, and we do encourage good communication. So if we're not on the phone because we're in clinic, then please email. And if there's any photographs you want to send over, we will get back to you and take a look. We want to try and prevent the problems from becoming big ones. Yeah. So we can nip the little ones in the bud quite easily, but once they become a big problem, then it's likely to cause a big interruption during rehab, and we don't want that.
That's really good, actually. That I believe that open communication is vital, because we might see something obviously with our rehab assistants who maybe see them most days or every day. They can pick that up, so that's good to know. Has anybody got any questions?
Oh, I did. Just on the back of what you were asking, Jill. I know you guys sort of answered it a bit earlier, but when you were saying about setting not quite expectations, but maybe smaller goals for people with limb loss, of what to sort of aim for going forwards, not the Paralympian strictly come dancing athletes, but the smaller goals. And I think people do, not just the clients, but family, rehab assistants, everyone around them might have this expectation of why aren't they achieving that. But do you work quite closely, or do you find it quite difficult trying to manage the expectation that it takes smaller steps, and we need to set slightly smaller goals, but a few of them going forward with clients?
From a prosthetic point of view, if anything, I try to be quite pessimistic early on, hoping that somebody will do far better. But I will be explaining to people that it's a very slow, gradual process. There's going to be periods of discomfort and sweats, and you need to build up very slowly. And then I'm happy for them to be better than that, but I'm trying to almost be on the pessimistic side, knowing that they don't think they're going to put their prosthesis on and go off and do a park run that weekend, which is not going to be the case.
But that is a big thing. I said lots of patients turn up, and especially in the early stages, they may have been pinning all their hopes on this for the last 2 or 3 months, waiting to come and see someone to get this sort of device. And so when we get to work with patients, it's that, like James said, it's being realistic, but then it's also managing the expectations as they're going through. They can start, when you first get a prosthesis, you're on this big upward trajectory, and then you sort of hit the everyday life, and it's sort of managing that point where they're not making constant down day progress or not making big progress. That's where it becomes those little goals to help them see what's happening. Because I find with a lot of my patients, when they're, I don't see them for 2 weeks, and they come in, I'm like, oh, wow, you're doing great, and they're like, oh, I don't really see it, because they've had those little gains day on day. So if you can use that goal setting process so they can sort of be aware that they are making progress, even if it is slower than what they'd like, that just keeps them engaged with their rehab, keeps them engaged with it, and motivated to keep doing what they're being asked.
Do you work with children as well?
Yeah,
we do.
Yeah,
yes.
we do.
Okay. Seem to have had quite a few referrals for children.
Yeah, with children, we have to be conscious of keeping them not only within rehab but school.
Yeah.
And so we'll often use school half terms and school holidays to do the work that we kind of can book in advance.
Yeah.
For children also, they need to have more than one device. That's very important quite early on, because these things do break. And when they do break, we need them to be able to continue at school and with the family while we sort it in good time, rather than scrambling around as an emergency to try and repair something if there's only one device. So yeah, children will often 2 devices and just good communication.
Yeah.
Yeah, and it's where local teams are really important, because again, we're not going to be pulling them out of school for physiotherapy, so it's making sure that, you know, where it can be provided within the school day or, you know, at home, that becomes really, really important. So that, yeah, because again, the therapy is slightly different. You know, it's especially with younger children, it's much more play based. It's getting them to just get confident using prostheses. Kids are quite adaptable, especially the younger they are, and it's just making sure that there is some oversight of how they're progressing. Again, and I tend to, with the kids I'm working with at the moment, play a little bit more of a back seat where I'm advising on the prosthetic or the orthotic components in terms of what I'd expect to be seen development-wise with the use, but then relaying that to a therapist who may not have that experience locally.
I was thinking, Alex, wherever you are, I can see you somewhere. I was thinking about your new client, but that might be useful to know. Has anybody got any questions? Any others?
I'll have a quick question. How do you see their journey for the patients with their mental health? Example that I've got is my client is amazingly motivated, really switched on and keen and driven, you know. But I can imagine in a year's time, he might just have a complete PTSD episode and things. Is that something you see and you work with other specialists about, or do you just see him motivated all the way through and just work on the legs and limbs?
The rehab journey, we know it's not smooth and linear. You know, we hope to try and smooth the bumps as best we can, but we know they're there, and psychological health plays a huge part of this. So if we let people know there's likely to be an issue, when they face that, they're probably more expecting and understanding that, okay, this is normal, rather than hitting a big down day. We also understand that what's going on in the background in terms of litigation plays an important role as well. And people get very down and very immersed in that world. And it does have an effect on what we're doing in clinic. So we're often given the advice, you know, let your legal team do what they're doing. That's why they're in place. And try and just let them get on with it. But we do see the ups and downs related to the claim, related to day-to-day use. We have psychologists available to us, and sometimes people come to see us with psychological support already in place, and that's perfect, that's fine. But yeah, a psychologist has a really important part to play in what we're all doing.
Thank you.
Good question. Okay, well, I'd just like to say thanks again. It's been really, really valuable and really interesting. And I think we've all got lots of information to take away there. So thank you, Pace, and I will see you again very soon.
Thank you, everyone.
Thank you.
Have a nice day.
Bye.
Thank you very much. Bye, everyone.
Shoes that they're allowed to wear. You're not a school, I'm just leaving.